Hi there, my name is Pillemer. I'm an orthopaedic surgeon with a particular interest in impairment assessment. In part one of this talk, I noted the various factors that we use in testing veracity and suggested that we have a column in our minds where we give little crosses for those incidents which make us doubt the veracity of the person. We do this consciously or subconsciously. I referred to Waddell's signs, in particular the straight leg raising test. What I would like to do in this talk is to discuss that other column in our minds where we give little ticks for what we regard as genuine behaviour, once again either consciously or subconsciously. When we get a whole bunch of ticks and very few if any crosses, we feel pretty confident that we are dealing with a genuine patient. We need to keep in mind, however, that even the nicest people exaggerate, and that an intelligent person who has had a condition such as a disc lesion with sciatica and who recovers will be able to convince even the most critical observer of ongoing impairment by simply mimicking the previously recalled symptoms and non-objective clinical signs of, say, sensory loss and motor weakness. I'm pretty sure that I've been taken in on many occasions, and beware the patient who tells you that he or she is not lying. These then are the signs and issues which over the years I have found so helpful in my assessments and which I will discuss. Eye contact. This is the first and most obvious sign, and a sign that is well recognized in psychological studies. The patient who makes and maintains eye contact gets a conscious or subconscious tick. However, be aware that there are other reasons for not making eye contact, such as shyness or lack of confidence. The smiling patient, particularly when compared to the patient with an unchanging mournful affect who fails to make eye contact. By the same token, in my opinion, every patient needs to be welcomed with a smile and a handshake, if appropriate, and an introduction which might be formal or informal, depending on your preference. From the country, after many years of being involved in medical legal work, I find that within a very short period of time, I have a good feeling with regard to a patient's veracity. And this applies particularly to patients who come from the country, who start getting tics almost immediately. There is not even a hint of the person being disingenuous. The squeeze test. I'm sure you will agree that the most difficult joint to examine in terms of veracity is the shoulder joint. Assessment of the shoulder joint is the subject of a future talk on its own. How do you assess the genuineness of a patient who will only abduct and flex the shoulder to the common 90 degrees? Well, I find the squeeze test very helpful. I ask the patient to squeeze my little and ring fingers with the normal side as firmly as possible. I then ask him or her to do the same on the painful shoulder side. I find the response very helpful in my overall assessment, particularly if the patient is only able to exert a very weak grip on the affected side. Many injuries, most better. When a patient who has had a number of injuries, say to the neck, shoulder, the back and the knee, and they tell you that everything has long since settled down, apart from the back, there is every reason to give a tick. The irritability test. Many years ago, I read an article by a doctor who described what he called the hypertension test, and this put into words something that I've been aware of but never clearly articulated. I've simply called it the irritability test rather than the hypertension test, as I can more easily recognize the symptoms in myself of the former rather than the latter. The only requirement of this test is that one is capable of empathy. I regularly find that when I start getting irritable with a patient, he or she is usually someone who is getting a lot of crosses rather than ticks. When I've analysed the reasons for this emotion, it is fairly clear. For example, the patient who takes an extra 2 seconds to answer a question, the patient who repeats every question before answering, the patient who asks me to repeat every question. These are all techniques that give the patient a bit longer to think of the answer. I find this an enormously helpful test. Taking the weight off. The intradiscal pressure in the recumbent position is 25 kilograms. It is well recognized that a far greater force passes through the lumbosacral disc in the sitting position, 140 kilograms, than on standing, 100 kilograms. The highest pressure is on sitting and bending forward while lifting a weight, 275 kilograms. A typical finding in a patient with a very labile back problem is for the patient to attempt to take the weight off the lumbar spine on sitting. When the patient sits in a chair with armrests, they will take some of their body weight through their forearms, resting on the arms of the chair. If the chair does not have arms, the person will take some of their body weight with one or other or both hands on the seat of the chair. Even on standing, the person will tend to keep a hand on an available item of furniture. I find this a very reliable sign. The family photo. This is a photograph taken in my consulting room and is the view which the patient will have while lying on the examining couch. On the opposite wall near the door are 2 photos of our family, one of my wife and myself with our 7 grandchildren, and underneath that a photo of the whole family. Every now and then, at some stage during the consultation, the occasional patient will say something along the lines of, "Is that your family? Those are wonderful photos." I then started to notice that in every case, the patients who made these sort of comments were patients I had given ticks all along the way. When I thought about it, the penny dropped. What I suggest is happening is that when a patient is not being entirely honest and has to concentrate on every answer, there is no time to relax and look around the room and see what might be of interest. I'm sure you will recall giving a history to a specialist, and while he or she is writing notes or prescriptions or a list of blood tests, you look around the room, you notice the certificates on the doctor's wall, the statue of the elephant on the desk, the family photos on the shelf. You are relaxed and able to take in your surroundings. For the patient to be obfuscating, there is no time to relax, as one is concentrating on getting the story correct, and there is no time to sit back and take in the surroundings. I find this a very useful test, and invariably when positive, putting in the final tick. Finally, I imagine that you will all have your own conscious or subconscious observations that tend to make you give the patient a tick. I'll be very grateful if you could let me know of these, and I will include them in a future talk. Once again, thank you for your attention, and I'll hope that you will join me for the next session. Until then, Salani Gashli.